Good afternoon, everybody. Welcome to the latest edition of Raising the Bar Live. My guest today is the CEO and founder of Health Here, which is a piece of technology that makes me so incredibly stupidly happy that we're going to talk about it today and why it does. So, Ryan, thank you for joining us today. I want to just say a couple of quick things about who you are. So, you are the founder of and CEO of Health Here, but you have spent your career in the healthcare industry and you are a serial entrepreneur. Before we get started, tell us how you decided that this piece of SaaS technology that you have created was the missing piece in healthcare.
Oh, yeah. So in my previous company in VivaLink, kind of on the tail end, and just to kind of give context, we somewhat stumbled into what now we would reference as value-based care, because really that term wasn't around. So this is 2009, 2010. Okay. And so being a Nashville-based company at the time, we really had these value-based models. I was like a Michael Porter protege of, what's value, outcomes equals cost. And we were incorporating that. It was around orthopedic, surgical procedures, mainly total joint. So essentially, we stumbled into what was the acute care episode demonstration. If we can recall, this predates BPCI as a bundle payment model. Because Nashville is Nashville and several of the health systems that were owned and based in Nashville corporate headquarters, we were introduced to that. So we were in 3 of the 5 sites in the nation live with this in VivaLink model. So I guess the takeaway from that is that I'm sitting at these board tables and you have C-suites of hospitals and you have surgeons and you have anesthesia and you have rehab for the first time sitting at a table and actually having a constructive conversation around an episode as compared to each person's silo and their, relative, what's in it for me kind of stuff, right? Which is understandable, that's where the incentive resides. So my takeaway from that experience was themes were right, model was wrong, right? Medicare can only do what Medicare could do, right? So they had to do a retrospective shared savings model because they were running it on the tracks of fee-for-service claims and thinking about how to scale a Medicare program. Obviously you can't re-engineer that type of thing at that type of scale right out of the gate, right? We didn't know if these themes would play out and play out well. So here's some of the key takeaways from that experience. Where it was most successful, the surgeons were highly engaged, and I would even say led. In the earliest days and as it evolved out. And if you look at the data, I think that's prevalent in some peer-reviewed study type things.
I want to circle back to that in just a couple of minutes, that part that this works well where the surgeons led, because I think we need to have a conversation about how value-based care works well and why it's good for the provider. But keep going.
Yeah, fantastic. To really just leapfrog, the takeaway, fast forward, in VivaLink, which raised capital with Blue Cross Blue Shield Venture Fund and HCA. HCA ended up acquiring in VivaLink to be their infrastructure for their orthopedic and neuro service lines and create, a path to value in that light. So I just being where I was, I stayed on for a bit to make sure that transition went as planned, but I really had this itch of, okay, I got a taste of this. And what would this look like if you were to build that model from scratch? Now that's a heavy lift, right? So Health Here was born out of this. We named it Health Here because we believe healthcare is always local, right? So even though we're in the same specialty, let's just focus on orthopedics today. I'll speak heavily to that because that's where we're most active. When you go city to city, as you know, there's nuance. Who are the major health systems? Who are the major payers? All those are variables that impact what a model can be like. And so we knew as a technology that we had to narrow the scope enough, but also provide a turnkey solution to enable a new payment model. So what that really translated to is a couple of problems, really. How do you sell something that isn't actively live? What is the cost structure for a provider to take that burden, right? So there's been a big hurdle for value-based. What's the financial incentive to invest in something that does not have a clear ROI? So Health Here built out multiple modules, right, that are seamlessly built together in the back end to create an episodic solution, patient facing, clinic facing, payer slash claims facing, TPA facing, however you want to frame that. And so we go in and we work with the specialist groups to serve for, there's point solutions for this stuff, but not all like a platform we have, but to provide utility out of the gate. And one of the biggest pieces here, if you think about how do we transition from fee for service to value-based care as a specialist, well, where's the money coming from to start, right? So the average specialist group is spending 64% or more on operating expenses. So we think about the root cause of these operating expenses. A lot of it resides in that administrative layer. That 30% waste we like to talk about in healthcare, a lot of it's around servicing, onboarding a patient, verification of insurance, prior authorization, claim denial, rinse and repeat, problems, a lot of headcount, right?
So let me throw in a little bit of context in there. So when I talk to providers, and I talk to a lot of providers about moving to a direct payment model, why they would do it, why it works, whatever, the number I consistently hear is 40% of our cost is collection. And I would assume that you see the same.
Yes. I think that if you lift up the hood just on prior authorization, you will see groups that are spending multi-six figures sometimes in servicing that problem. Like a sizable group, 25, 30 search income group, right? But an independent practice that is has its own prior auth department, that doesn't feel right to me, right? So I understand the themes on why prior authorization exists, but it's a blunt instrument that has done nothing but throw sand in the gears and raise the cost of care delivery, right? So yeah, so there's not that we don't have to. I think there should be the definition, and we should quantify appropriateness and effectiveness, but not with that tool, because that's not really solving the problem, right? So and then we bake that into these episodic models. But to rein it in, we knew we had to go to the specialist groups and offer an immediate ROI and utility. And our story is we're going to reduce your operating costs. That money can be reappropriated to build new models, right? So our Cube solution, which is really the direct employer episodic solution, is the technology piece that allows them to price, build, and scale these models. So it's kind of like we're teaching them how to fish, and then we're giving them the toolkit to self-serve this, because that is the most effective and efficient way to stand up such a model, right? Because we don't need a ton of middle layers. We have, if you think about, I'm just not interested in creating a zero-sum game. If we don't shrink the total cost of care, we don't shrink the pie, and if we don't allow them to get effectively either equal or bigger slice, what's the financial incentive? So there's the problem in value-based care. If you do not have an immediate financial incentive and you're only showing a cost burden, I don't see how you come out and go from 0 to 1. Right?
I agree.
Yeah. So I'll speak a lot from a provider viewpoint because it's what I know best, but the intent is to free dollars to generate savings that will be, enjoyed by an employer that's trying to reconcile these over year cost increases. So that's our approach. I'm very much a specialist first approach as compared to that traditional sort of center of excellence approach. It's not a health system centric approach. It's like getting to the front line on the specialist level, enabling them, and providing scale in a very cost effective manner.
I want to talk for a second about what that looks like in real life, because we've got some examples in San Antonio, which is where I am. And there is a school district that has engaged with a local vendor who is using Health Here to facilitate this process. And what that looks like for a member is a member goes to the doctor, they get referred to this particular specialist. And when they get referred to that particular specialist for, let's say, a knee surgery, because that's just the one we all talk about all the time, right? So for this particular specialist, the knee surgery is about $25,000 bundled price. So the surgeon, the anesthesia, the facility, the knee, right? So all the things that you need are right in there. They're mostly done on an outpatient basis. The facility knows what their costs are. And the member shows up with their ID card. They hand over their ID card. They have no idea that the employer is paying a lower price for this care unless there's some sort of incentive on the back end, different conversation. And then they get scheduled, they get their care, they're done. The employer has agreed to the fee up front. The charge is the invoice, because it's an invoice. It's not CPT code, claim form, blah, blah, blah. It is, here's an invoice. This is what we did. You need to pay us now. And that may be the day before. It may be the morning of. It may be 2 weeks later, whatever the terms are that are set up. The employer saves that money. So in San Antonio, they're paying $25,000 for a knee rather than 36 or 42 or 79 or whatever the day's charge is for a knee. And they contain their costs. The employee gets a great experience and the provider gets paid.
Right. Totally.
Quickly and fairly, and probably a little bit more profitably than if they had to go collect that money from an insurance company.
Yeah. I'll say just on that note on the very end, I came to this world before health here, probably more biased on clinical workflow, had a lot of knowledge of, care delivery, maybe less so on revenue cycle, right? From a provider's lens. I was very shocked to learn over time how much in these central billing offices, like the head count, the work effort, the time consumption on, like you mentioned, the 40% collection problem. And I'm also very surprised. And when you think about the themes, when we talk about what you just detailed, what resonates with not only the anchor provider being the orthopedic group, the facility and anesthesia, just saying, we will pay you within days, like 15 days or less, basically based off the check run of the employer would be the rate limiter.
Correct.
Be the payment, right? Because we own our own payment rails, right? So we are the episodic claim generator, we are the ACH fund flow mechanism, and we are the technology that manages all the distributions.
And
so that's key.
Let me clarify for an everyday person what that means. What that means is that Health Here is managing the entire process. So whatever TPA you're using as a self-funded employer, they're going to get information from Health Here that says this service was performed according to our specifications. All the checks have been checked off. All the TPA needs to do is add that to their next check run and release it. So it is a much shorter process. And I think much fairer. I think providers wait, maybe they get paid in 30 days and then in 90 days they get a clawback for it or part of it, and then that has to be reconciled. There is absolutely none of this here. So for an employer, it's easy, right? It's coming on the check run. Oh, look, here's our knee replacement this week, done, paid. And for the provider, they've been paid, and the member, their user experience is not disturbed. Because that is a big problem with a lot of solutions like this, is that the user experience is disturbed. And that can be very upsetting. Healthcare is very personal to people, right? Nobody wants crappy care. Nobody wants to, think they're not being treated right. So this is a really simple way. It is literally the switch.
Yeah, and just speaking to the member experience, patient experience scenario, and where we've put a lot of engineering energy, and I think it's important to note as a differentiator how we're why we're different. So we're integrated into the EMR practice management system of any anchor provider, right? So we're surveilling all these insurance profiles. So that is how we actually engage with a member before their appointment. We'll actually educate them on there's an enhanced benefits workflow. So we will ping them via text upon appointment creation, let's say. And as you know, depending on what model, you might actually activate a benefit for it just being automatically happening. But we're doing that engagement pre-visit, and we can even swim further upstream upon scheduling. It's a longer conversation. But as they show up for their appointment, we're also activating that practice management system to make sure it's not processing on that primary insurance that's still going to be presented, as we all know, right? Like they're going to show, X carrier, regardless of this benefit. And so there is a win-win there immediately for both the provider side and the member side. And then, education level, process level. So that's really where, it starts there. And then if and when it becomes an in-episode event, which is predefined, I think it's something very important to talk about. We enable our providers to essentially publish an episode library. Any line item in that library is not executable until the employer / benefits consultant, whoever the stakeholder on the other side, accepts that. Then it is publishable, right? So there's a line item level technological check and balance there. And in that, you have to really define your covered services. So really what we're talking about here is transparency, right? So if you're going to create a cost ceiling, what's in those covered services? Very well defined. So anyone that's not even really familiar with the nuances of that respective surgery, whatever, they're going to be able to parse out like, okay, here's what's covered, as is the patient. So the patient actually receives a very patient-friendly description of covered services, which is meaningful because typically patients are receiving first dollar coverage on these benefits, meaning no deductible copay will be associated with that defined episode. Is a typical scenario because that is the incentive to review this anchor provider as a preferred provider for that respective diagnosis, whatnot, or procedure. Does that make sense?
It does absolutely make sense, and I think it makes sense when you talk with employers about it. It makes sense that they understand the unit cost, right? So if you can have a consistent unit cost, it's never always going to be exactly the same, then you can budget more effectively. Because certainly for the school district that we're talking about, they're actuarially creditable, right? They know they're going to have 15 knee replacements a year. Well, do they want to pay $25,000 a piece for them, or do they want to pay an unspecified amount for them? Right. And I think what we're seeing in the industry, those of us that work with these kinds of solutions, is more and more of these episodic care solutions where the tech is supporting it. And I want to talk about that because the healthcare industry, I mean, half of it still runs on fax machines. So it is not a big change agent kind of industry. Talk a little bit about what your experience with that has been, because you are quite a technological change from a fax machine.
Right. I mean, I think that's, for me, always been the biggest motivator. It is a huge challenge to navigate a highly regulated space as a technology company. So, there's always a lot of rhetoric around disruption, whatever. Well, you have to work with the incumbents or you're not going to be able to navigate the ecosystem. Sometimes very much our rate limiter will be which EMR company we're talking with, that, what level of integration are they comfortable with? Are we getting in their space, right? So there's challenges there that, we are tying multi-stakeholders together on a technological platform. A lot of education has to be done on how this is a win for all, as compared to a challenger. That's real world stuff that I don't think is ever going to go away. But I will say though that my experience I'm very much a product oriented CEO this time around compared to my previous. We have so much infrastructure and tools, so you can be highly creative and very fast moving on the innovation cycle. Now, the challenge in healthcare, as we know, is it's not a fast moving purchaser of anything. We know the employer side, we know the provider side is just as slow. And even you might think that the specialist groups move faster than health systems. I'm not sure that's quite true either. And so you have long days of sale, you have high cost of sale. If you're a subscription model like us, we can't afford to do all that work and then lose a client. So you have to be sticky. You have to show your value and be sustainable. So as a technology company, you have to be fairly, lean and mean to get there. So because you have to have staying power to build your brand, but certainly you have to have trust to get bought, like by that stakeholder. And then you have to prove yourself to maintain, to do the things we're talking about today. It took 5 to 6 years of building. I mean,
No doubt.
no exaggeration.
How do you sustain your team through that?
I think that everybody on our team is really genuinely passionate about being in the healthcare space, and there's plenty of options. If you're a talented engineer, there's so many industries you can go to. But I think that the cause, in that, hey, if our core, is the patient provider relationship, that's kind of what we use, is like, if you want to call it a North Star type concept. Like, if we distill everything down to, are we honoring the patient provider relationship, then I feel like no matter what, we're in a good place. History will treat us well. That then everything kind of unfolds from there, right? So I think that thinking we have our team, the tenure's longer than the average startup. So people stay, and I think it's because the mission is of great value. I think that has a legitimate reason.
I think the mission is of huge value. We directing people to a high quality, well-priced provider is a challenge. And you have eliminated about 80% of the challenge, I think, maybe a little bit more. So I think that's a really important thing. And that is one of the things that we hear from employers is we don't want to get in people's business with their healthcare. We just want to make sure they have something decent. And I will tell you, they don't say they want to be the cheapest thing. They would like their employees to have the best thing.
Yeah. That's been so interesting to me. And again, as we're interfacing with the specialist side a lot of times, and we talk about these things, and you'll hear the classic, is this a race to the bottom? When we start talking about, value and cost equation. And I say, listen, I've actually been in the rooms with the HR teams, and it's exactly like these, back in the med school days, I don't know if they still do it. They used to teach the 3 A's, right? It's availability, affability, and ability, right? And so if you think about how that translates to what the employer / member / patient wants, they want convenient access to care, right?
And well priced.
They want and they want a not a terrible experience, so frictionless care delivery, tech enablement, we're in that space. And they don't want a confusing experience. And then obviously ability, right? Like, so the outcomes capture piece is something that's still near and dear to my heart. I've done it since my last company, whether it be a net promoter score capture or a functional score capture, we are folding that in. It is a current offering. It's more like waiting for the market to mature to that level to incorporate that into the equation. It's there and ready, right? I think that it is important for us to recognize that this has to be a sustainable model. It can't be a one-trick pony and a side service transfer and like, oh yeah, we went from inpatient to outpatient and now we recognize X dollars, and then what's happening next year? We have to very much grow into a longitudinal episodic model where it will go from data service, 90 days of care, to plus 90 by conservative care. How do we manage all those care dollars as long as possible in an accountable manner? That's our goal, right? Like when we talk to specialists, that's like, there is a crawl, walk, run process here. And we know it's a long journey, but come out of the gate and do this data service with an employer. I love it. I mean, it's really interesting to have the employer side engage directly with the specialist. We do showcases where the specialist group actually talks about their offering. It's like an epiphany, right?
Yeah.
I'm like, why doesn't that happen all the time? And I'm telling these specialist groups, why would you not want to build a direct relationship with this major employer in your community? You are a community-based company, essentially, right? Why not
the independent physicians are all about the community. Right? This is where we live. This is where we work. This is, we want to engage. And I've heard that from several of your providers is we didn't know how to do this before Health Here, right? So now we have a mechanism where we can do this, and it is not exactly plug and play, but we're almost there.
Yeah. I don't want to oversell and oversimplify. However, I do think we have reduced the barrier of entry significantly. It's been
Yes.
proven, right? We just went from a day of implementation that was 96 days from first phone call on a benefits consultant, first call to an employer, to implementation with an anchor provider with a full suite of episodes, 150 CPT codes, right? That shows you that, and it's not a huge metro market. Like, this is a school district in a mid-sized town in the state of Tennessee. It's not, it doesn't just happen in San Antonio and Nashville and Charlotte, right, or whatever. So I think that's really interesting.
But I think that's also part of what it takes, right? It can't take 6 months to do these things.
Yeah.
Right. And when we set up data analytics and we set up some other services, it takes 90 days because there's 5 different parties and everybody has to agree. And even if they've agreed before, they have to agree again, which means that the lawyers have to look at the contracts and some of that's just part of it. Right. But 90 days is a much better time frame for that than 6 months. People have forgotten in 6 months. Even the people that want to do it have forgotten in 6 months.
So true. So
that is a shorter, that is a better thing. And I think that school districts are feeling a pinch across the country now, more so than they ever have. And they're also, our clients will typically say to us, look, we spend a lot of money, we spend a lot of time. Could it just be better? Let's get to better, then we'll deal with less cost. And I think you handle both in one instance, and that's quite a feat to accomplish.
Yeah, I think that we're going to see a significant evolution of how we measure or demonstrate quality if you let go. The irony is, let go of fee for service. You have a blank canvas to design. Quite frankly, okay, simple thing during COVID. Of course, we stood up a telehealth product within our patient-facing, clinic-facing platform, and everybody would be doing it, right? Well, guess what? The orthopedic surgeons quit using it because the commercial payers quit paying for it. There's no reason why you can't have an MRI follow-up with your patient via a nice, well-integrated telehealth solution, but now if it's in episode and we're not really encounter-driven, we're episode-driven, we don't care. Like, we're just managing the total cost of care delivery, right?
I want to circle back on that a second. I think that's, people are always, I just have a sinus infection. I get a sinus infection every year. Why do I have to go there? Why can't I just tell my doctor what I need? And, as one of those people that gets one sinus infection every December 15th, I just want to pick up the phone and get my Z-Pack. I don't want to have to go there 3 days later and sneeze and be coughing over everybody, and the same to me. And when you move to models like direct primary care, direct specialty care, bundled episodic care, you throw all that out the window, right? Because those people trust that you are a grown person, you have a reasonable idea if you have a sinus infection, and we'll circle back to make sure that was in fact the case. And this is just an extension of that. And I think that as more and more people experience direct primary care, and that's certainly growing rapidly in San Antonio, and we're not unique, it's growing in a lot of places, that people will understand that, and people will start to push back on, I'm not coming in, we can do this virtually.
Right. And it also speaks to, you can't offer just one modality, right? There's no specific, let's talk about orthopedics. You can't have, I'm not a big believer that you can virtualize all services, right? There is an augmentation strategy. So there again, that's where it begs for, you need freedom in your care delivery model and the respective financial incentives. But if you're managing to the total cost of care, you can figure that out, right? Like, you can, and if you have, and I'd love to hear your perspective on this. I still think about the scenario where, isn't it interesting that the provider side really hasn't had a voice in how they get paid since when, right? And so how are they supposed to deliver the best product if they don't know or aren't able to present a package? They're like, well, this is how we can really productize this, and our operational model will support it, and this is the best product we can deliver based off this model. That opportunity hasn't really existed for a very, very long time.
I
And I don't know if your side ever thinks about it that way, but I just think I never hear it talked about.
we think about it. We think about it when we have people that are in a direct primary care environment and we need to get them to a specialist. Then their experience changes pretty dramatically. Unless we have something like Health Here, where we can guide kind of outside of the parameters of the plan. And what has always been very interesting to me is that when I have an opportunity to talk to a doctor, then he said, well, this only costs this, we can do this for this, and this is no problem. But that message often doesn't get conveyed to the front desk staff. And before I upset people, I don't mean to. I think that front office people in doctors' offices, outpatient surgical facilities, any hospital systems, they are the most overworked and underpaid people in the building. And they have 975 things to deal with. And if they make a mistake, then there's 10 mistakes further down the road that happen. So they're just trying to do the right thing for the most part. But if we can help those people relax and simplify their lives, then I think everybody's experience would be better. Doctors could create products that they want. They could create service models, treatment plans that they want, that don't necessarily depend on 3 office visits, right? Mm-hmm. It may take 2, it may take 1, it may take 5. But most doctors understand what happens and how their specialty needs to be treated. And if we could take the temperature down for the front desk staff and help them not do things that really irritate patients, then everybody's temperature would be taken down, and employers would pay a fair price, because employers are still paying for 50% of the population. That's where healthcare is coming from. Not going to change anytime soon. Ultimately, maybe, but not today. So 50% of our population is getting their health insurance delivered through an employer. So we can contain those costs. Most employers really want to do the right thing for their employees. They'll lower their out-of-pocket costs. They'll eliminate them. They will reduce their premium contributions. I have a client that just eliminated their premium contribution for all tiers, right? So they'll do those things. And then if we can make sure that providers get paid fairly and quickly, then you have some homeostasis, right? You have providers that are getting what they need. You have patients and employers that are getting what they need. And we're returning the system to local, because healthcare is always going to be local. Okay, you may need to go travel for this one thing, but you're not going that far to get your knee done, right? You're not going to,
There's no reason for it. There's just zero reason. Very few markets don't have a capable and
exactly. So let's find the capable people, make sure they get paid fairly and quickly, and let's let the whole community participate in that, and then let people's wages go up and let everybody's temperature come down. To me, that's a worthy goal. It's kind of a big lift, but a worthy goal.
Yeah, but a worthy one. We're very excited, and just seeing the market show the temperature has changed, I would say. And this is a sampling that's pretty broad across the country. When I reference that I do sense that the self-funded employer world is demonstrating their willingness to transition into non-traditional models. And so I'll go a step further. There are independent orthopedic groups that have already self-organized. And as a collective is 4,500 surgeons and 5,000 physical therapists that have all created a very clear mission as to what a high-value specialty network looks like. Evidence-based clinical pathways, standardized processes, transparency leads. So, it's funny. Like, I feel like there's 2 sets of market that are both wanting the same thing that still have yet to be connected in a lot of spaces, right? So we hope that's what we are. Like, we're this digital bridge to bring these 2 parties together and do it in a really effective manner that, delivers better care. That would be, to me, a big win for U.S. healthcare.
I think it would be a huge win for US healthcare. And I think that there are plenty of local providers who would like to figure out how to do this. So we'll get this out there so people can know where to find you, because I think it's important that people find you, not just you go hunting for people. And also, you've been doing this for some time now. Is there anything that you wish you would have done differently?
Yeah, it's a tough one in the sense that I think on a philosophical level, I don't look back on specific, let's say, big, decisions and parse them out. My philosophy, and just doing this for over a decade now, as in sort of the early stage side of things, um, is resting in. I'm making the best decisions I possibly can with as most information I can get my hands on.
Which
So
is
you
never
kind of get to that 80% level, right?
yeah.
And my discovery is that there are very few situations or decisions that you make that you really can't pivot out of. That's very rare. So I don't like. In other words, I think that can create paralysis.
Yep.
We have to be bold. We have to make leaps, and sometimes they're very scary leaps. So the thing that I really focus on, and I've talked about with our team, I've never made a good decision based out of fear. So if something's rooted in fear, you can almost guarantee it's
Sure
going
it's
to have a
wrong.
bias. They're like probably not the right move. So
Yeah.
there's this level of fearlessness, but somewhat calculated and educated fearlessness. You don't want to be just running into a brick wall at full speed just because you think you can. But that's how I manage that. Now, maybe that's just self-preservation by not processing some of my past mistakes. I've made plenty of mistakes. But I think to keep going forward, you got to just, give yourself a little grace in that I'm trying to make good decisions, and you got to make, hundreds a day essentially.
Yeah. Every minute.
I tell this story, and anyone on my team's heard it too many times. So, when I was in college, and I was trained to be a whitewater river guide, right, on the Curry Rivers during when the Olympics were going to be. We thought we were going to just be so busy, whatever. It turned out to be a really slow summer. But point being, I remember training, and there was this one rapid where you had to go river left or river right, and I really couldn't remember. So my first trip, it was just made such a big deal, and I froze, right, and so I obviously wrapped the raft right around the central rock, and my entire boat just boom, just released of all the people, and so now I'm salvaging 6 to 8 people in the water. And then I go down again, and then I went river left, and then I'll go down again. I went river right, and then the story is make a decision.
Yeah.
Not like
I froze.
it was a disaster, right? So I've kind of used that as an analog for how I make decisions around here. You got to make one, and timing might be more important than the actual decision. So that's my take on that.
So what is next for health here?
Well, I'll say that job one for us is to scale these models across the country, and that's proving out. So, we've gone from Tennessee to Texas to Florida to North Carolina, and now we're going to the state of Washington. So very excited about just showing this multi-geographical footprint evolving. And then it's filling in the robustness, if you will, of the technology to continue to enable to go longitudinal. So imagine really managing the total cost of care on an annualized basis. And then obviously the opportunities to next specialty. When I say next, right now, musculoskeletal is job one. It's the market wants it, needs it. We know it best. So, cardiovascular market, oncology, women's health. There's key opportunities. I think we're not going to get ahead of ourselves. We know we have to execute on where we are today. But going across specialties and creating high value specialty networks in major metro markets is the vision. And just us to be the enabler of that. And it'll take different forms in different markets. But that is where we are focused.
I'm looking forward to your next market.
All right.
So since your MSK market is working so well in San Antonio.
Yes, it will be exciting to make the next move.
Yeah. Thank you for joining us today. I will, this will be out on all of our social channels, and we'll get it out a little bit further as well. Thank you, Ryan, for joining me today. And until we will see you on the next episode of Raising the Bar Live. Thanks for joining us.
Allison, thank you for having me. I really enjoyed it.